So good afternoon, ladies and gentlemen. It's my great pleasure to introduce you Dr. Rukshana Shroff, and she's a consultant in pediatric nephrology at Great Ormond Street Hospital for Children in London, UK, and I'm pretty sure you all know her. She has fabulous work on cardiovascular disease and dialysis, and she's part of the editorial board of the Clinical Journal of the American Society of Nephrology, Pediatric Nephrology, and PD International, and she's a leader of the CKD Dialysis Working Group of the ESPN and ERKnet, and she's a board member of the ESPN CKD and Dialysis Working Groups. And today she will discuss the access for pediatric dialysis.
Thank you very much, Rukshana. Happy New Year, everybody, and thank you for starting off the ERKnet webinar season again. I just want to confirm that you can actually see my screen, everyone?
Yes.
Okay, thank you, Justine. Okay, so my remit for the webinar today is to talk about access for dialysis, PD and hemo. We'll start with PD. We'll look at the types of PD catheters, their complications, and a few common guidelines around that. We'll then look at access for hemodialysis, looking at central venous lines and arteriovenous fistulae, and briefly discuss the one-stop vascular access clinic that we have set up. Lastly, I'll just briefly mention our ESPN clinical guidelines, which will now be published in NDT. So, access for PD. So you see this picture of this lovely little boy here showing off his PD catheter. Let's look at different types of catheters, their placement, complications, and guidelines. So Tenchkov catheters can be either straight with this sort of swan neck, or coiled, or a combination of the two. And on the catheter end, as you see here, there are multiple small openings to allow for multiple exit sites for the fluid. You'll also see the cuffs here and the importance of the cuffs, which we'll talk about in a minute. So there is usually a permanent bend between the two cuffs, which allows the downward pointing exit. This memory of the plastic that allows it to keep its shape and its configuration, and is one of the most important factors in firstly allowing you to have a downward pointing exit site, and secondly in maintaining that. So here you see the pediatric swan neck curl catheter, and as you will see in this picture here, this is exactly what is shown on the outside of the container on the box. It shows you the distance between the cuffs and the tip of the catheter, the distance between the two cuffs as well, and the overall length of the tube. So measuring up the catheter is important. This diagram is slightly misleading because clearly you would not do it in an unsterile way like this. But in the operation theatre and before the catheter is inserted, the surgeon has to determine where the exit site for the catheter will be, so that they can be sure the correct length of the catheter is obtained and the tip is as deep in the pouch of Douglas in the pelvis as possible. This picture is a figure showing you the placement of the two cuffs. So here you see the external cuff which is just under the skin, and here just below the rectus sheath is the internal cuff. And this is where the actual functional part of the catheter starts. So what is the ideal position of the PD catheter? The tip of the catheter must be in the most dependent part of the pelvis, which is the pouch of Douglas, and it is by being in this position that you can get the optimal drainage possible. This figure here shows you, where is the tip really? And if you can see it clearly on your figure, the tip is actually up here above the level of the iliac crest. And you see there's a large amount of fecal moving throughout the abdominal cavity with a complete opacification in the pelvis, suggesting that the patient is severely constipated. And as a result of that, the catheter tip is probably slipped and moved out of the pelvis and so high. So this is another complication with a PD catheter. And here you see very interestingly a lot of omentum trapped within the catheter pores over here. So this is clearly, this is an infant's abdomen. This is the PD catheter being actually removed because of malfunction. And at the time of removal, you can see the exit site was here. At the time of removal, you see just what a mess it is and why the catheter has not functioned. So let's look at this. How would you prevent this complication? Now, I'm going to go to the poll section here and select the question, which I hope will work. So this should come up on your screens now. Tanya, can you confirm for me this is working, please? And can you all see the question? So
Yes.
the poll is now
Yes,
open.
yes, yes.
Thank you. Excellent. Thank you. So the poll is now open, and the question asks, how will you prevent this complication? And you are allowed to take multiple responses. So, excellent. We're getting lots of responses here. Very good. Okay, few more seconds, guys. Let's go through this. Okay. So, moving on to the answer now. Poll results. Okay, let's look at that. I I don't know if you can see it on your screen, but what I can see on my screen is that most of you have got the correct answer. And if I move on here, which I can't do at the moment. Okay, yeah. So looking at this now, the possible ways of preventing this complication are by doing either a partial or a total omentectomy, or by hitching the peritoneum, so stitching the peritoneum to the omentum, sorry, to the parietal peritoneum. And these are the three possible ways to try and avoid this complication. I have to say that in practice, what we do most often, as in almost all our patients, is a partial omentectomy. A complete omentectomy is a very, very difficult procedure unless you have a massive surgical scar and you have a complete exposure of the abdomen. In a lot of adult centers, they prefer to hitch the peritoneum with a few stitches up under the diaphragm. And by doing that, they prevent the omentum from sort of bunching up around the tip of the catheter and they keep it at a far distance. So most of you got the correct answer. Well done with that. So let's look at catheter-related problems. These can be associated with a one-way obstruction. That means you have a good inflow of fluid but a poor outflow. Or you could have a two-way obstruction where both inflow and outflow are a problem. So looking at one-way obstruction with the inflow, this could be because of constipation, which is by far the commonest reason. It may be because of catheter migration into the upper quadrants of the abdomen. And again, this itself could be because of constipation. And thirdly, it could be because of an omentum wrap, where the omentum has bunched up tightly against the end of the catheter, just like the picture I showed you. So to manage this, a very careful attention to bowel preparation is important. What we would do in our center is we would do almost what the surgeons do as a bowel prep before they actually put in the catheter. So they'd actually, so giving a, not quite an enema, but giving a very large dose of laxative to clear out the bowels. We would thereafter keep a very close, every time in clinic ask about a history of bowel preparation, about bowel movements, and use laxatives if necessary. Omentectomy at the time of PT catheter, I've explained this, and sometimes stitching the catheter into the pelvis. So now looking at two-way obstruction where both inflow and outflow may be affected, and this could be because of a kink or a bend in the catheter. So the lumen of the catheter itself is completely or partially or completely obstructed because of an actual mechanical problem. It could be an intraluminal obstruction, such as with fibrin or with blood clots. Now, managing this in some centers is done by radiological insertion of a trocar in order to straighten out the catheter. This can be quite high risk. I have to say, in my center, our surgeons prefer not to do this, but in skilled hands, it has been used. The second and more commonly used method is to flush the catheter with heparinized saline or with tissue plasminogen activator, and to try and dislodge any fibrin clots. You know, once you have fibrin sheath starting, it's the start of a biofilm. It's the start of a risk of infection. And really, in this situation, you probably want to keep the catheter clear with using regular, as in sometimes weekly, or even more frequent, several times a week, heparin added to the PD fluid. So something to think about there. Now, here is an unusual situation where PD can be performed in a patient with a colostomy. Clearly, it's not something that is desirable. It's a colostomy like an ileostomy is a dirty incision, and there's a high risk that your patient can get infections from this. There are two reports in the literature about PD in the presence of in the simultaneously with a colostomy. The PD catheter in this case is sometimes tunneled along the chest wall with an exit site actually high up on the chest wall or even on the back. I've seen situations like this. The balance is to keep the exit site as far away as possible, but at the same time, the longer your tunnel, the greater the risk of infection. Let's look at another scenario. So some of you, I'm sure, have seen patients with an abdomen like this. You can see that this boy actually had prune belly syndrome or Eagle-Barrett syndrome, and therefore has a very lax abdominal musculature. You see the scars of several previous operations, including a previous kidney transplant. You can see a mitrophanol here as well. And if this child had failed a failed transplant or failed hemodialysis, and the question is, is he suitable to have PD again? Now, there are very few cases in pediatrics, but in the adult literature, there's this very nice paper where they have shown that out of 217 successful catheter implants, 43% of that cohort had previous abdominal surgery. And looking at this Kaplan-Meier graph, you see that there's no difference in the catheter survival, the overall catheter survival, in those who had previous surgery or did not have previous surgery. And here they see that some patients had adhesions, and irrespective of previous surgery or adhesions, the outcomes are not different. And therefore, if you have a child with an abdomen like this, I wouldn't, at one glance say impossible, we cannot do PD. If you are in a difficult situation, it may be worth considering and trying PD. Okay, so the next question is a Cochrane review was published in 2004, which stated that the following catheter-related interventions are important for the prevention of peritonitis. And if I go to the polls again and come up with this question, can you all see this? Yeah?
Yes.
Excellent. Thank you. So let's go through these answers. Again, you could have multiple correct answers here. So which of the following catheter-related interventions are important for the prevention of peritonitis? Now remember, this is a Cochrane review, so they've looked at the highest quality, highest level evidence to try to say there must be at least several randomized trials to give you this data. There's one other thing I have to clarify for you, and that this study is done in adults and not in children. Okay. So let's do a few more seconds and then go through the answers here. Okay, it looks like most of you have made up your minds. So let's close this and look at the answers here. Now I can see from this that there are multiple different choices that people have selected, and I'm sure most of you are right in most of what you've said. But when you think about the Cochrane Review and the very high standard of evidence that they look at, what they believe in through their randomized trials is that the only thing that determines the success of your PD catheter and prevention of peritonitis is the use of straight versus coiled catheters. These are the results from 3 different randomized trials. They're all performed in adults on PD, and they've all shown that a better outcome is seen with a straight rather than a coiled catheter. The straight catheters are shown to have improved primary function, improved PD technique survival, and a lower risk of catheter migration. And again, like I said to you on one of those initial slides, the internal memory of the catheter is the most important factor against catheter migration. I know that we often talk about a downward pointing exit site, and a downward pointing exit site is known to reduce the risk of exit site infections, but not peritonitis. But it's therefore clearly an important factor you wish to keep in mind. So a straight rather than coiled and a downward pointing exit site. Okay, so we need to move on with the hemo section. So let's briefly conclude on this. We've seen that there are comparable outcomes with different types of PD catheters and insertion techniques. The local expertise should govern the choice of the catheter used and the catheter insertion technique, keeping in mind these few points we discussed with the Cochrane Review. And finally, most catheter-related complications are preventable, constipation being the most common, and then, of course, keeping in mind the need for a partial omentectomy as well. Okay, so I think we'll be doing questions at the end. So let's move on now with hemo access. And let's look at this. So 2 young children, one with a central venous line and one with a fistula. I can tell you that this boy with a fistula was just over 3 years of age and weighed about 13 kilos at the time. So, which of the following should not be used for chronic dialysis? Now we're going to a higher age, to a 10-year-old child. So, if we go to this question here, which of the following types of lines should not be used for chronic dialysis in a 10-year-old child? Take a look at the question, please. And again, you can have multiple correct or multiple wrong answers. And remember, this is chronic dialysis, so long-term dialysis, where you want to try and choose the optimal vascular access possible. And I think this is a fairly easy question, but we will be going through all of these points together. Okay, so great. So the large number of you have already made up your minds. So I'm going to move on now. And what we can see here is that actually none of these lines should be used for chronic dialysis at all. Clearly, a single lumen catheter is not ideal. An uncuffed catheter is not ideal. Oops, sorry. A double lumen cuffed catheter, but in a subclavian vein is again, a double lumen and cuffed is a good idea, but not in the subclavian vein, because subclavian vein lines are associated with the highest risk of stenosis, and therefore you compromise your future vascular access. A Hickman line clearly will not be used for hemodialysis, and an arteriovenous graft in any situation and any location is a last-ditch sort of rescue attempt. So a few years ago, there was an International Pediatric Fistula First initiative. This was following the Canadian initiative of Fistula First in adults. This was then moved forward for children as well. But a nephritic's report looked at the outcome and the success of this call. And actually, sadly, you can see that the rate of central line use since that call was initiated has actually sadly increased. So this is, of course, US data. And in the US data shows that over the last 2 or 2.5 decades, the use of a central line has increased to nearly 90%, and the use of catheters and fistulas and AV grafts has dropped substantially. Now, looking at European data, our colleague Wesley Hayes had done a survey across the European Pediatric Dialysis Working Group and shown the prevalence of different catheter types across the EU. So he showed that arteriovenous fistulas are used in over 1/3 of patients, and then tunneled single cuff or double cuff lines are used in about 60%, and only 2% of patients have arteriovenous grafts. So this is important information, keeping in mind the guideline or the Fistula First initiative says versus what the actual practice is. Now, the International Pediatric Hemodialysis Network, the IPHN, is very shortly going to be publishing their data. Is soon going to be publishing their data, and they have shown that out of 550 chronic hemo patients, 55 across 55 units around the world, the prevalence of I'm sorry, you can't see it very clearly on there, but the blue is clearly the central venous lines, the red are the arteriovenous fistulas, and the green the arteriovenous grafts. And you see again that by far the prevalent common use is with central venous lines. As the children now grow older and above the age of 10 years, the number of arteriovenous fistula use increases quite to some extent, but it's still less than half the use of central lines. Now, looking at central venous catheters, a large number of studies, even in pediatrics, have looked at outcomes with central venous catheters compared to arteriovenous fistulae and shown that the risk of death, of infections, of poor dialysis adequacy, and of thrombosis are all increased with central venous catheters. All of these different factors are increased. Let's look at this scan here. So you see this photograph here of this child, and then you see his arteriogram. And what I would like to do is to ask you a question now about what you see on this photo and what the scan shows. So let's start this question. Take a look again at the photo and the scan and tell me what it shows. In the same patient, what is the conclusion you draw from this imaging? So while you're doing that, you can see that this young child has quite a swollen face and perhaps the neck region as well. So quite marked swelling on the upper part of his body. You can see at least some marks of a line here, and probably something here. You see the scar of an abdominal surgery, and you see a huge number of dilated and tortuous veins along all over his chest wall and on his abdominal cavity. And this picture implies that he may have a neurological deficit in his left arm. You see also the arteriogram here as well, and the picture on that. So now most of you have voted. So let me close that and let's discuss what we see here. So what we see on here in this photo is clearly superior vena cava syndrome with dilated chest wall, dilated veins along the chest wall, and a significant swelling on the upper part above his superior vena cava drainage area. You also see on the arteriogram bilateral and complete occlusion of all his central vessels. And this is really, in such a young child, this is a devastating picture. This says to you that putting in any future line is going to be extremely challenging. You see clear stenotic areas. In fact, this child has had multiple balloon dilatations as well, and sheets inserted. And also, this tells you that in the future, performing an arteriovenous fistula on his arms may also be a high risk procedure and actually fail because the central drainage is so poor. The IPHN registry has looked at the vascular access survival, and here you see at about 48 months or 4 years, sorry, the survival from an arteriovenous fistula or graft as an access survival is far superior to the survival of central venous lines. There's a very recent paper in pediatric nephrology just this month, which from the US, from the Midwest region, which has looked at the outcomes of fistulae versus grafts. And there in their analysis, they have shown that arteriovenous fistulae have a far better primary and secondary access patency compared to arteriovenous grafts. So this is in pediatric nephrology this month, if you want to look it up. Okay, so then we come to the clinical course associated with the vascular access type and the risks associated with this. Now, this is a US-based study, excuse me, a US-based study. And here they've compared hospitalization from all cause, infection-related or access complications. And they've compared vascular catheters, central venous lines, versus what they call permanent access. And permanent access for this paper is our AVFs or AVGs. You must keep in mind that these are not permanent. No vascular access is permanent. But comparing these different access types, you see that the hospitalization rate for all cause is higher with central lines, and the infection-related hospitalization is significantly higher, as in 4.5-fold higher with lines compared to access. Okay, so a few words now on our vascular access clinic. About 7 years ago, we set up a one-stop vascular access clinic to try and limit the number of, to try and streamline the process and the concept of having of promoting arteriovenous fistulae compared to a line. In my center, we very strongly believe, as I'm sure many and all of you should and do, that the veins are the lifeline of our hemo patients. And so this message, save your veins, save your life, is extremely important. You will see this in adult dialysis units. If you were to walk into an adult dialysis unit or even the renal unit phlebotomy site, you will see this message, which tells people, do not allow somebody to take blood from your antecubital fossa. That is extremely important. Save those veins for the future. And so the strategy in our vascular access clinic is to see the patient early. How early, of course, is interesting and debatable. It depends on the child's nature of their kidney disease and how rapidly progressive it might be. The whole ethos of this is vein preservation or preserving access. We always try and use the non-dominant arm before the dominant arm. We prefer to do a distal before a proximal fistula, always a native, as in an AVF, before an AVG, and where possible, avoid the central venous catheters. So non-dominant limb is an important concept. The child sitting on the hemo unit will want to write, will want to play, will want to keep themselves busy for the time. But equally and more importantly, these days when everybody has their iPad, you can do it with both hands. But what you can't do with your non-dominant hand is to try and needle your fistula. And here we try and promote the children, teach the children how to needle their own fistulas. So the parents or then the children learn to do their own self-needling. And this goes a long way in preserving the access integrity. Now, When the patient comes to clinic, the vascular assessment strategy is twofold. One is a clinical assessment, and the second is the ultrasound-based assessment. So, on clinical assessment, you want to look at the all of a whole number of parameters about the access, from its size, its how much you can dilate it using a tourniquet, the continuity of the length of vein available for the fistula to grow and mature, and for your needling sites, whether it is straight or tortuous, and how deep it is below the skin. And of course, the state of the central vessels is extremely important, like I showed you in that previous figure. So here, the assessment is done with the patient in a warm room. It's important. You don't want peripheral vasoconstriction. You want to then check also by applying a tourniquet to make the veins as prominent as possible, and then eliciting the Lewis response, which is basically overlying the site of the veins to actually just rub the skin to increase the temperature, increase the resistance, and then you see the veins popping up more prominently. When the surgeons actually operate, they will use things to dilate up the veins and papaverine to make them prominent. So the second part of the assessment is the venous assessment with an ultrasound scan. Here, our ultrasound department will look at will image both arms, really from the clavicle all the way down to the wrists, and there'll be two measurements at each level. It is with and without a tourniquet. At each level, you have two measurements, and a full comprehensive assessment of the veins on both arms is performed. I'm going to fast forward a little bit now to talk about fistula cannulation. So typically after a fistula is formed, we advocate a period of maturation for the fistula, and this period could be between 4 to 6 weeks. It needs a further ultrasound assessment, and of course a clinical and an ultrasound assessment at that stage. But the timing of the first cannulation is extremely important. And this very nice study has shown that if the fistula is needled before before 30 days, then the risk of damaging the fistula is far greater than if you wait for 45 days or after for the needling. And this is, of course, a small and a non-randomized study, but it's still a very well conducted study in children. And based on these data, we advocate a 6-week waiting period at least. So 6 weeks, re-image the fistula, re-evaluate it, and then decide whether they're ready for needling or not. The techniques for cannulation are 3 different types. An area puncture, so cannulation within the same region or same area within on the vein. A buttonhole technique, where needles are placed at exactly the same site and exactly the same angle and depth at each dialysis session, and ideally with the same nurse or the same person doing it, so that the continuity and the consistency is there. And then over a period of a few weeks, you create a track, so that this track can then in the future be needled with blunt needles. And each time the needle is removed, a scab forms over it, and this gives you that sort of a more permanent tract or access. A very important factor is that there will be a scab. That's the only way that the bleeding stops. There will be a scab overlying the area of the buttonhole, and the scab can be prone to infection. So if you have a patient who, for example, may have eczema or have some skin disease, or where you're concerned that their overall hygiene is not that perfect, then you have to very carefully consider the risks of sepsis and infections versus the risk of benefit from a buttonhole. In most patients, we recommend buttonhole technique in my center, except those where you're concerned about sepsis. The third technique for cannulation is the rope ladder method. Now, the rope ladder means that just exactly like a ladder, you change your needling site every time, and the sites of the needle puncture sites are selected each time at a different level. Now, clearly, you need a distance between the two needles for any type of these 3 cannulation techniques, and it is recommended that the distance should be about 4 centimeters at least, ideally much more than that. Now, in a small pediatric fistula, where the whole length of the fistula may actually be 4 centimeters, you're unlikely to be able to successfully rope ladder. And what then ends up happening is, instead of hoping, well, you hope to do this, what you end up doing is actually area puncture. So we need to be very careful about the technique selected and ideally go with buttonhole where possible. Okay, now once a fistula is formed and used, it needs regular surveillance. The European Renal Best Practice suggests surveillance every 3 months. Um, we in our center do between 3 and 6 monthly, but with very careful clinical assessment at every dialysis session, and then an ultrasound assessment perhaps every 6 weeks. So the surveillance required includes assessing the adequacy of dialysis, assessing the blood flow rate, looking at clinical problems, and clearly such as post needle removal bleeding, looking at diagnostic imaging and the dialysis parameters, so the adequacy on dialysis, and a physical examination. So all of these different factors with an ultrasound assessment every 6 months. And this is the ERBP recommendation. So psychological preparation for access is an extremely important factor and clearly depends on the age of the patient and their requirements. We have a DVD which is actually available online on YouTube as well, with this girl actually talking about her story with a fistula and how advantageous it was. We also have preparation and desensitization techniques using everything from these dummy dolls and all the needles that the children can put in them, as well as reward charts, role play, messy play, written step-by-step plans, and some children have a kidney book, which our play specialists work on with them to make them understand why they have a fistula, what the benefits of it are. One of the big benefits many children will quote to us is that they can swim with a fistula, whereas they couldn't do that with a line. So one important thing to keep in mind is once again this very important message of preserving vascular access. So this study performed through the ERADT registry looked at the number of changes in access in the type of renal replacement therapy before a patient reached the age of 18 years. So the majority of people had no change or only one change. So you could argue that in the best case scenario, they've had a preemptive transplant, or they've gone from preemptive one type of dialysis modality to a transplant. However, you see that 25% of patients have actually had 2 or even more than 3 different changes of dialysis modality before they have their transplant. And the important message from this is, and you need to preserve vascular access for the future. We see patients till till the 18 or 20 years of age, but actually they have a lifetime ahead of them for renal replacement therapy, and preserving their veins is an extremely important factor. So last slide is on the ESPN consensus document we have produced as a team effort between the dialysis working group members, with input from adult nephrologists as well as from trial methodologists. This will be available online as open access in early 2019. I've put just one slide here. You can see that we've attempted to grade our recommendations, and you can see that all of them are very low grade. So the majority of these are consensus statements or opinion based. You need to, of course, interpret it carefully. Sorry, I've got a meeting going on. You need to interpret this very carefully in the context of what is actually happening, what is actually relevant for your patient, and take it from there. So thank you all for listening. And I want to end on a cute picture, but actually more importantly, I want to end on an important message, which is save your babies, save your life. That is extremely important for the long-term preservation and health of our patients. Thank you very much. And last thing I have to tell you is about the next webinar, which is on 22nd January with Dr. Lars Papa. Thank you.
Thank you so much, Rukshana, for this wonderful and very practical and clear overview of PD and HD access in children. And if you have questions in the audience, you can send them through the website, and I will read them to Rukshana. I think I had a few technical problems with the sound, and I hope that it was only with my computer. But I think one of the main thing is that we need a local expertise for both access. And in Lyon, for example, we are facing some problems with the creation of arteriovenous fistulas. And I was wondering which kind of subspecialty of your surgeon do you have for this creation? Because we can have vascular surgeons or urologists or orthopedics sometimes, and which specialty do they have in Great Ormond Street?
That's a very good point, Justine. So this, I think, varies with local specialisms in different centers. One of our transplant surgeons, who's actually a vascular surgeon, has made it his special mission to work on access, and he has in fact actually come to Paris and learned from from Professor Bocole, and Professor Bocole and his team have amazing experience and interest and results with vascular access. They use microvascular surgery, and they have shown very, very good outcomes with access. So I think, as you correctly say, the number of children is always a small number. The expertise really needs to be developed, and it's extremely important that this is done, with a few people in a few specialized centers to develop this.
Yeah, I completely agree with that. I think that the save your veins, your life theory is completely correct, and I wonder whether it could be like a promotion through ERKnet. I'm just waiting for the questions for the audience, so please don't be shy and send me your questions, because I don't read any question at the moment. But what's your view on the ERKnet network to enhance this save your vein, save your life message?
I think that's a really good point, and it's an excellent means of spreading the message as well. As we put in our access statement and said this is something important that needs to be implemented, and actually the patient and their parents need to be empowered to do this. So we in our center try and teach a lot of teach all our nurses and our junior doctors and our phlebotomy staff. But equally, this is something that patients and parents themselves can say. And we try and develop YouTube videos and messages for people to try and follow with this. But we will be very happy to share this through ERKnet, absolutely, and to share it equally, to share it as videos and links like that as well.
Yes, I think it would be a great idea, and then probably to translate this message into the different languages we have. I also have another very practical question, and I don't see any question on the GoToWebinar, so please go ahead. Do you, how many patients self-needle their fistula in Great Ormond Street? How do you proceed? Like, how long does it take for a patient to be independent for this self-needling? Because I think it's really interesting, and probably we have been too shy to try, but it could be probably interesting in teenagers.
I think you're absolutely right. So, like for any patient with a new fistula, our nurses would first needle it. Where possible, we try and create buttonholes. So, we create the track for the fistula needling. And then, once that track is created securely, and the patient can actually move from sharp to blunt needles, then it becomes a much easier teaching process and a much easier system for them to learn. And we try and follow that pathway. Sometimes the parents prefer to learn, even with young children, Even on our home dialysis program, we have parents who do this. So we try and build up that skill. And along with the dialysis nurse, one of the most important people doing the teaching and helping are actually the play specialists and the youth workers we have. So they try and have a system with the patients about what they want. In terms of the pain relief with it. Do they use Ametop spray? Do they use Ametop cream? Do they use a spray? What their strategy for coping with pain is? And most children actually learn best by seeing other children doing it. So the children who are confidently doing it on the dialysis unit start allowing other children to see it and to learn from them.
Oh, okay, this is very interesting. Maybe we should try. Anyway, we just received one question from PD, so we will switch to PD, and I will read the question, Rukshana. So, as feeding and nutritional needs will be a concern in an infant with CKD pending ERK, when is the best time to consider inserting a gastrostomy feeding tube? Is it at the time of PD tube insertion?
That's a very good point. So again, with a gastrostomy insertion, if there's actually a chance to plan and prepare this carefully, then the best time to do this is to do it before the PD catheter is put in. And so the ideal time for a gastrostomy is before, maybe even just 1 week before, but before that PD catheter goes in. If that is not possible and if you're caught in an emergency, there are some centers who do both simultaneously. But I know that there are some recent reports from the US that have shown that it may not be that effective. If there is absolutely no time to prepare a patient for PD, or if you're in the situation where your patient has come in very sick, then the final step is where you actually you have to do a PD, you have to do a gastrostomy after a PD catheter, and that also is possible, and it has been done reasonably effectively. But the important thing with that is then that you have to do an open procedure. So so basically the stomach cavity is kind of lifted out outside the abdominal wall, and then the stomach is punctured to put in the gastrostomy tube. So essentially, you do not want a spillage of gastric contents into the abdominal cavity because that is where you can end up having peritonitis, and actually the most dangerous type of peritonitis, which can be fungal peritonitis. Yeah. And of course, you want to cover with antibiotics and antifungal agents. So if you actually have to do a PD catheter simultaneously with the gastrostomy, then I would cover with antibiotics, metronidazole, and antifungals.
Okay, thank you, Rukshana, for this really clear answer as usual. And I think we do not have more questions. So I would like to thank you all for being there this afternoon. And again, thanks so much, Rukshana, for this really nice review. So I will tell you, see you next in the next 2 weeks for the next webinar, and have a great day. Bye-bye.
Thank you, Justine. Bye. Thank you.